So we're going to talk about a topic that's complex, and I'm going to try to keep it simple for everyone's enjoyment and understanding. There's going to be a little redundancy in my talk so everybody gets the basic points. The main thing is that sagittal alignment, the way that your head sits over your pelvis, and the way that your lumbar lordosis is curved is a very important part of your overall health as you age. In the beginning of spine surgery, let's say 25 years ago and greater, people were looking at things very simply. How do I decompress this nerve? How do I take this tumor out? How do I maybe stabilize a listhesis or some kind of spinal segment that's causing my patient pain? But what we learned is that spine surgery is very, very complicated. And you have to keep a lot of things in mind, both before surgery, during surgery, and after surgery, including, am I going to actually cause this patient the requirement for more surgery in their lifetime just by what I've done to their spine? In my opinion, and this was ingrained in me during my training at Northwestern for 7 years, we talked about it all the time to the point where I don't really want to talk about it anymore, but I feel like you guys need to know about it now. You got to think about what the spinal alignment is every surgery, whether it's a microdiscectomy, whether it's a minimally invasive or open or a T-lift or a ACDF or a O-lift or a D-lift. You got to think, how is the spine aligned, and can I mess it up? Can I fix it? Or can I just leave it as it is? The good thing about being a young spine surgeon is that I got a lot of patients coming down the pipe, right? People are getting older, people are healthier, they're living longer, more educated, they're going to want more surgery, they're going to want good outcomes. But that also means more complications, so we got to know what we're doing and we got to do it right. This is just a graphic that demonstrates the U.S. Census estimates an increase in population, as we all know. That's the trend. More patients. And having more patients, including more elderly patients, means I'm going to see a lot more degenerative scoliosis or spinal deformity or kyphosis of some kind, and more need for my services. And the big thing about that is that is a direct impact on someone's quality of life, their disability scores, how they feel, how their day-to-day goes. When you have spinal deformity and it's symptomatic, your life is not fun. For instance, look at this. Symptomatic adult spinal deformity is about as debilitating as living with cancer. Okay? It's not as bad as not being able to use your arms and legs, not as bad as having heart or lung disease, but it's as bad as having cancer and going through that. We know this is debilitating to our patients. Another graphic demonstrating that, which we'll skip over because it's a little hard to look at. But why is it so debilitating? So Jean Debussy is a French scoliosis and deformity surgeon, quite renowned, and he came up with this theory of what's called the cone of economy. Your body is supposed to be in perfect alignment, your head above your pelvis. Lean to one side or the other, forward or back. It is hard to do things. It's hard to just walk, right? It's hard to go to the store. It's hard to drive. It's hard to do everything we need to do in life on a day-to-day basis. When you deviate from that cone of economy, you have to use more energy in order to do these things. And that leads to pain, fatigue, and not a happy life. Dr. V is going to like this. In my opinion, we are all biologically still hunters and gatherers. We are supposed to walk the earth and look for food and hunt for food and protect ourselves and our family from people who are trying to hurt us. We cannot do this if we don't have a horizontal gaze across the landscape. It's biology. We've got to be upright. And as you can see, since we came down from the trees and began evolving as hominids, Until we became Homo sapiens, we have gotten more and more upright. Our pelvis has changed and evolved. Our spine has changed and evolved. Another example of that. We were pitched forward, now we walk straight. And from the time you are in the womb, when you're an embryo or a uterus, to the time that you die, your spine is going to evolve. It starts very kyphotic. You are in a C shape when you're little. Then, when you start learning how to sit up, you get a cervical lordosis, a nice curve to it. Then, when you start to stand and walk, you get a lumbar lordosis. But you always maintain your thoracic kyphosis. All three of these things are incredibly important. And as we age, we fall forward. We get shorter. And that can lead to people having bad neck pain, back pain, and all kinds of problems. The question is, how do we help them surgically? You want to be straight up and down, both in a coronal plane, that's forward, right? You don't want to be bent this way and have a scoliosis. And in a sagittal plane. You don't want to be bent forward or backwards. This is a nice example of someone with good spinal alignment. You see that line? The center of mass of the cranium, the C7 plumb line, straight up and down. The head is above the pelvis in both planes. Very important. I bet you'd be much happier if you were the first picture than the second. We all understand that. Same patient, forced forward, can't stand up straight. This is just another graphic that shows you and proves, and this is published in a reputable spine journal, that as your sagittal balance, so positive sagittal balance is when you lean too far forward. Your disability scores go up and your quality of life goes down. Proven time and time again. So it's very important for people as they age for their quality of life. This is just an example of a bunch of different, what we call patient-reported outcome scales. This is how we learn. How does the patient feel before and after surgery? Did we make a difference? Did we help them? They have to fill out a ton of paperwork. Everyone at B&A knows that. The PAs and the docs, they complain all the time. So much paperwork. But it's very important. Otherwise, we don't know, did we help you or not? How do we decide what to do? Same way we always do in medicine. We do a physical exam, right? We take a history. We look at these patients. Do they have shoulder discrepancy, a hip discrepancy? Do they have a hump, when they bend forward? Are they stiff and rigid, or do they have flexibility? Do they have a leg length discrepancy? All of those things are important. And then, of course, we move to radiographic stuff. Let's take some x-rays. Obviously, that is a radiographic problem. That patient has a coronal and sagittal malalignment, and both are severe. With surgery, although that looks very aggressive, a bunch of screws, a bunch of rods, that patient is doing better. I know this patient. We operated on them when I trained. So, how do we decide what to do surgically once we decide someone has a surgical malalignment problem that needs an intervention? To begin with, you take what's called a C7 plumb line. You go to the mid-body of C7, cervical vertebra number 7, and draw a line straight down to the ground. And then you draw a horizontal line from the back of the sacrum to that plumb line, and it should be approximately 5 centimeters or less aligned, right? Because if you think about it, if your head's down here, you're positive. If your head's up here, you're aligned. 5 centimeters is the rough number we're trying to achieve. It's patient dependent, but that's the best result we can get. Again, a lot of this is redundant, and that's for the single purpose of I want everyone to understand the basic principles of spinal alignment. Restoration of your sagittal balance, keeping your head above your pelvis and femoral heads, is a quality of life issue. It's been proven over and over, and it is very, very important for how you perceive and enjoy life and your disability as you age. Most of this talk is focused on adult deformity. Adolescent and pediatric deformity is a completely different talk, which we're not going to get into today. And again, this idea of a cone of economy. You must stay in a certain cone with your body so that you can not have pain, not waste energy, and go out and kill some elk V. So let's talk about the radiographic parameters. Okay? The SVA, very important. I touched on this briefly already. The C7 plumb line, right? You got to draw a line straight down to the ground from C7 and then measure it back to the sacrum. You can tell this patient obviously is pitched forward, and I bet this patient is not feeling very well. 5 centimeters or less is the goal if you operate. Pelvic incidence, very important concept. This is when you get your standing scoliosis x-rays at the hospital, AP and lateral, and you measure from the midpoint of the femoral heads to the sacrum, perpendicular line, and that angle right there is one of the most important things in spine surgery, in my opinion. You have to know what someone's pelvic incidence is. The reason for this is because pelvic incidence is a constant for the most part as soon as you are skeletally mature. Regardless of your other pelvic parameters and your other spinal alignment parameters, this is kind of the goal that you must pay attention to. You've got to correlate your lumbar lordosis with your pelvic incidence. It should be within 10 degrees or so. They should coincide. And as you can see on the left, it's a nice curve, right? You see the sacrum kind of pointing one way, and the lumbar spine comes in, and you got a nice lordosis there, and it just looks like it flows well. That's what we try to achieve in surgery. You see the patient on the right is obviously hunchbacked. It's not flowing well at all. And this is just a bar graph that demonstrates as your lordosis and your pelvic incidence don't match, you do not feel good. You feel disabled. You cannot do things you want to do. So, on the left, you see someone who doesn't have a very high pelvic incidence, and so you don't see as much of that swan lordosis, in their low back, but they're matched. It looks good. And on the right, somebody with a slightly higher pelvic incidence has a slightly higher lumbar lordosis, and they match well. We talk about a pelvic incidence to lumbar lordosis mismatch when we are planning a deformity surgery. Got to get them matched up. Just another graphic demonstrating the same. If your pelvic incidence is not that high, your lumbar lordosis doesn't have to be that great, and then vice versa. So, what do people do when all of a sudden, I'm 60 years old and I'm starting to degenerate and I'm getting a flat back deformity or sagittal malalignment? The body starts compensating because, again, you got to keep that head above the pelvis and the femoral heads. It's the only efficient way to do life. You start bending your knees, you thrust your hips, you change the alignment of your pelvis. Your body does this. It works for a while, but the problem is that it requires a lot of energy, you become tired and fatigued, and people develop a lot of back pain. It becomes a structural problem. It becomes a problem that potentially surgery can cure. See how that patient has to change their alignment in order to stay centered. Pelvic tilt, that's kind of the parameter where people are changing that the curve to their pelvis, the alignment of their pelvis, because they're trying to keep their head up so they can look straight ahead. And this is how it all ties together. PI equals PT plus SS. One of the most important equations of my training since I started school. Now that I'm a neurosurgeon and a spine surgeon who has done a deformity fellowship, you have to match those numbers up correctly, or you will not achieve success for your patient. And this has been proven. Again, multiple studies, reputable institutions, very good spine surgeons. If your pelvic tilt is not correct, if your pelvic incidence is not aligned with your lumbar lordosis, you most likely do not enjoy your day-to-day. This is what we're shooting for. Again, you want your head close to your pelvis, within 5 centimeters of the sacrum, the back of the sacrum, posterior portion of it. You want your pelvic tilt less than, we usually shoot for about 20 degrees where I trained. And you want your pelvic incidence and your lumbar lordosis not mismatched, but within approximately 10 or less degrees of each other. We measure these things with x-rays before surgery, during surgery, and after surgery to see what we need to do for our patient, what we've done in surgery before they wake up, if we need to fix something, and then after surgery to see what result we got for them. There are other factors that, determine how we achieve the goals of correction. Some people have a very flexible spine despite the fact that they're malaligned. You put them on the table. We talk about this all the time. I know all the OR nurses in here have heard us talking about it. Let's put them on the table and see what happens. Maybe we don't have to cut osteotomies or lose as much blood. Maybe they automatically correct, and we just have to lock them into position. But you also have to take into consideration their age, how sick they are, how much surgery do we really need to do for them. And so every patient's goal is different, but we're always trying to get that perfect goal if we can. And again, this is just another example of an aligned person, someone who's trying to compensate, and then someone who just can't compensate any further and may be a surgical candidate. Again, another graphic demonstrating that we all fall over and shrink as we get older. And then it's up to the spine surgeon to determine if surgery might be helpful to improve quality of life. Similar graphic. Again, I'm just trying to make a point. And again, as we age, right, we lose height, we fall forward, and then we try to compensate. Most of us get through, and we're doing fine, and we don't ever have to have a big scoliosis or kyphosis surgery. Sometimes people need it. So it's a big deal, right, having such a large surgery. But we've proven that lumbar lordosis and sagittal alignment are super important in terms of your quality of life. So if we operate on it, is it going to help you? And the outcome data is very supportive of that. It's a big deal having that surgery, but it helps you. At 2 years, people who had surgery were feeling much better than those who hadn't, despite the fact that they had an all-day surgery, maybe a 2-day surgery, maybe lost 2 liters of blood, 3 liters of blood. People do better, and that's why we put them through it. It's as dangerous as open-heart surgery, but when it works, people are happier. And this shows similar. And this, if you look at the p-scores, less than 0.001 for all of them, that is incredibly statistically significant. This surgery helps people in a lot of ways. Same with this graphic. Less than 0.001 in most of these categories. This is a helpful operation if it's done correctly on the right patient. Now, complications. If you do such a big surgery, you can expect complications. Absolutely, 100%. You got to talk to your patients about what they're signing up for. You got to be very frank with them. I've seen people do fantastic, and I've seen people perish from the worst, terrible complications you can imagine. Fungal infections on bed rest for 6 months until they finally pass. So you have to have good patient selection, and you have to educate them. I generally will not operate on these patients until I've seen them in the office with their close loved ones at least 3 to 4 times before we decide to operate. Complication rates can be high, 10 to 40%. And that's what I tell them. Sometimes you got up to a 1 out of 50%, 50-50, you're going to have something happen to you during your post-operative course, intraoperative course, that is not going to be super awesome for you. But we'll try to get you through it. Most of the time we do. Now, age. Age is probably the greatest predictor of a poor outcome. But at the same time, and I'll show you this in a slide or two, even with age, older people actually, when it goes well, do better than people who are younger than them, if they make it. They're going to make it. Don't worry. Poorly worded. And this just shows you here. As you get old, you put it into 3 categories. A 25 to 44-year-old person, they're going to do okay, right? Someone in their middle age, that's the sweet spot, right? You're not too old, you're not too young. They're going to do okay too. The older people have complications. You can get them through it though. And this study was done by a cohort of a lot of different surgeons from a lot of really good institutions who combined their data. This basically says the same thing. And again, statistically significant. Very statistically significant. Same. So as I alluded to, despite a higher rate of complications, older patients do get better, more disproportionately even, greater improvement if things go well. It takes a while for people to recover, even young people. I usually quote 3 to 6 months before we kind of see where you're going to land. It's a long time. People have to make a commitment. They have to be good patients who listen and want to get better and have support. So this is an example. 82, okay, pretty old. Back pain, 30 years and severe left leg pain. She's got obviously a radiographic problem, right? Look at that scoliosis. You jump at that x-ray, just say, oh my goodness, she's going to need a T4 to the pelvis. Well, maybe she doesn't. And this is why. There's just lateral recess stenosis there on the MRI on the left side. So, patient selection, very important. Do the smallest surgery you possibly can. If that surgery happens to be a minimally invasive discectomy, do that. If it happens to be T10 of the pelvis, you got to do it. But this one ended up being a minimally invasive tubular discectomy, and the patient did well. Different patient. Obviously, you can see this patient's tipping forward. You have what we call a flat back deformity. 64, so not as old, middle-aged, in a better place age-wise. You see how this patient is bending their knees, trying to compensate, keep that head above the pelvis, but they're in a good age range. So you fix them, and they do well. It's a lot of metal, but now that head's back over the pelvis, and they're not bending their knees as much or moving their pelvis as much. So, picking your patients, incredibly important. And there's so many components to this. What's their past medical history? What's their nutrition status? What is their bone health? Do they smoke? Where do they live? Who do they live with? Who's going to take care of them after surgery? What are their goals after surgery? What are their expectations? Surgery is stressful. They have to be able to tolerate it physically, emotionally, and mentally. High-risk surgery. Greater than 6 levels, greater than 6 hours. I try to stage my surgeries if I feel like things are going too late in the day. I never start an operation like this unless it's a first start. If I'm starting to lose too much blood, I'll stop and stage it. And I always have them evaluated by anesthesia, their medical doctor, and everything beforehand. Check their albumin levels, check their bone health, and if they have poor bone health, they need to get a bone health evaluation, DEXA scan, at least some vitamins, maybe Forteo, Prolia, something stronger, and I'll make them wait for weeks or months until they get some time to get that in their systems. This is a group of the people I trained with that did what's called the high-risk spine protocol, which is basically what ERAS is, I guess now as we would call it. Too bad our visiting doc couldn't be here because that would have been nice. But, we all know that pain management and medical management of these cases is super important, and we have to pay very close attention to it. There are so many variables that go into it, and all of them need to be addressed. Osteoporosis and bone health, of course, very, very important in terms of good outcomes. So surgical planning, this is a little bit more, technical for most of us here. But the question is, how do you get that patient back in alignment? As I stated earlier, sometimes you can just put them on the table and they correct a lot. And then sometimes you have to cut osteotomies of some kind, bend your rods a certain way, reduce the spine to the rod in a certain way. So I'll just gloss over that. But certainly the surgeon is always thinking about that part of it. Finally, when you get your patient in the operating room, you've established they're a good candidate, you've established all of their preoperative risk factors are acceptable for surgery, then you got to think about how am I going to get this job done for the patient. Several kinds of osteotomies you can do. I try to stick to what's called a Smith-Peterson osteotomy or a Ponte osteotomy or a Chevron osteotomy. They're basically the same things. But sometimes you have to do a pedicle subtraction osteotomy, known as a PSO, or a vertebrectomy. Those are higher risk because you're going to lose more blood. And then, of course, most of these slides, honestly, could be its own talk. But when you're thinking about how to correct someone's spine, you're thinking about what kind of deformity they have, how bad is it, is their spine stiff, right? We do bending x-rays before surgery sometimes, so we know if they're fixed in a deformity or if they actually have laxity to their spine. And again, bone density, what are our operative goals? If you got an 80-year-old, you just want to correct enough to make them feel a little bit better. That's different than someone that you want to make absolutely perfect because they have 30 or 40 more years of life. Obviously, radiographically, a bad scoliosis, coronal deformity. What would you do? The SVA is 5, which is pretty good. That's about where you want it. Pelvic incidence is higher than the lumbar lordosis. Remember, we wanted 10 degrees. So not completely aligned in the sagittal plane. Smoke. They use prednisone. Have colon cancer. History of pneumonia, trach and a peg, right? Do you want to operate on that patient? No, even though their x-rays look bad, right? And then there's a different kind of patient. A little bit younger. Not so bad. Both of them got surgery because my attending is crazy. But I would never operate on the one that was that sick in my practice. It's case by case. But anyhow, it's just my attending kind of bragging on his work. Again, ideas of upright and supine x-rays, right? So you want to know what happens to somebody when they bear weight, right? When you lie down, it's going to be different than when you stand up. So just an example of how we have to do preoperative x-ray planning so we know what our surgical goal is going to be. Both of them got big surgeries, but look at the alignment. Much better. These patients did well. They were happy, despite having so much metal in their body. I operated on the one on the right. This is my mentor, Dr. Koski. The biggest thing about deformity surgery is don't make a quality of life problem into a life and death operation. So plan every step of the way. We want to help our patients, but is this patient the right patient to have surgery? Okay, maybe. Let's look into that. Let's get our appropriate films. Let's measure our pelvic parameters. Let's know what our surgical plan is going to be going in. And then let's be safe in the OR. Let's prepare for the future. Let's prepare for a problem in the ICU. Let's prepare for a problem 3 months from now if the screw pulls out. Let's make sure our bone health is okay. Let's make sure they don't smoke. All of these things are super important. You can do good work for people if you look at all the variables and you think about them. You need to look 1,000 yards down the road to be a good spinal deformity surgeon. And this is an algorithm that we came up with at Northwestern when I worked there, kind of putting people down a certain pathway, trying to think about what's the best thing for each patient. Minimally invasive deformity surgery is something that some people have looked into. We used to do a lot of open operations. That's a whole different conversation, but I will let you know that that is an important part of, how you characterize who is going to be the best for what surgery. And that is kind of something I wanted to mention because robotic spine surgery has come into the forefront now. Dr. Rajpal is going to talk about robotic spine surgery later this afternoon. And how do we incorporate robotics into spinal deformity surgery is going to be something that's going to come to be over the next 5 to 10 years, in my opinion. And I'm hoping to be a part of that. So appreciate you all listening.